Welcome to the Dr. Izzy's Medical Podcast channel.
Erythropoietic Protoporphyria. Erythropoietic protoporphyria is a form of porphyria, which varies in severity and can be very painful. It arises from a deficiency in the enzyme ferrochelatase, leading to abnormally high levels of protoporphyrin in the erythrocytes, plasma, skin, and liver. The severity varies significantly from individual to individual. Erythropoietic protoporphyria usually presents in childhood, with the most common mode of presentation as acute photosensitivity of the skin. It affects areas exposed to the sun and tends to be intractable. A few minutes of exposure to the sun induces pruritus, erythema, swelling and pain. Longer periods of exposure may induce second-degree burns. After repetitive exposure, patients may present with lichenification, hypopigmentation, hyperpigmentation and scarring of the skin. Erythropoietic protoporphyria usually first presents in childhood, and most often affects the face and the upper surfaces of the arms, hands, and feet and the exposed surfaces of the legs. Most patients, if the erythropoietic protoporphyria is not as severe, manifest symptoms with onset of puberty when the male and female hormone levels elevate during sexual development and maintenance. More severe erythropoietic protoporphyria can manifest in infancy. Erythropoietic protoporphyria can be triggered through exposure to sun even though the patient is behind glass. Even the ultraviolet emissions from arc welding with the use of full protective mask have been known to trigger erythropoietic protoporphyria. Erythropoietic protoporphyria can also manifest between the ages of 3 and 6. Prolonged exposure to the sun can lead to edema of the hands, face, and feet, rarely with blistering and petechiae. Skin thickening can sometimes occur over time. People with erythropoietic protoporphyria are also at increased risk to develop gallstones. One study has noted that erythropoietic protoporphyria patients suffer from vitamin D deficiency. Liver failure. Protoporphyrin accumulates to toxic levels in the liver in 5 to 20% of erythropoietic protoporphyria patients, leading to liver failure. The spectrum of hepatobiliary disease associated with erythropoietic protoporphyria is wide. It includes cholelithiasis, mild parenchymal liver disease, progressive hepatocellular disease and end-stage liver disease. Diagnosis. Erythropoietic protoporphyria is generally suspected by the presence of acute photosensitivity of the skin and can be confirmed by detection of a plasmatic fluorescence peak at 634 nanometer. It is also useful to find increased levels of protoporphyrin in feces and the demonstration of an excess of free protoporphyrin in erythrocytes. Screening for FECH gene mutation on one allele or aminolevulinic acid synthase 2 gain-of-function mutation in selected family members may be useful, especially in genetic counseling. Liver biopsy confirms hepatic disease and erythropoietic protoporphyria. The presence of protoporphyrin deposits in the hepatocytes that can be observed as a brown pigment within the biliary canaliculi and the portal macrophages. Macroscopically, the cirrhotic liver can have a black color due to protoporphyrin deposits. Using polarized light, the characteristic Maltese cross shape of birefringent crystalline pigment deposits is found. The examination of liver tissue under a Wood's lamp reveals a red fluorescence due to protoporphyrin. Liver biopsy is not helpful for estimation of prognosis of liver disease. Treatment. There is no cure for this disorder, however, symptoms can usually be managed by limiting exposure to daytime sun and some types of artificial lighting. Most types of artificial lighting emit light in the problematic wavelengths, with fluorescent lighting being the worst offender. Color temperature can be a good indicator of what light is most detrimental, as the higher the color temperature, the more violet light is emitted. Incandescent and LED lighting in the soft white range produce the least problematic light. Additionally, selecting lower wattage bulbs can reduce the overall output of light. Since the photosensitivity results from light in the visible spectrum, most sunscreens are of little use. Sun protective clothing can also be very helpful, although clothing with UPF values are only rated based on their ultraviolet protection and not on their protection from the visible spectrum. Some patients gradually build a protective layer of melanin by regularly exposing themselves for short times to ultraviolet radiation. Window films which block ultraviolet and visible light up to 450 nanometer can provide relief from symptoms if applied to the patient's automobile and home windows. An example of such would be Matico Amber 81, which can protect through the 500 nanometer range. Blue blocking screen protectors can help provide relief from symptoms caused by televisions, phones, tablets and computer screens. Erythropoietic protoporphyria is considered one of the least severe of the porphyrias. Unless there is liver failure, it is not a life-threatening disease. Approved therapies. Afamelanotide, developed by Australian-based Clinuvel Pharmaceuticals, Was approved in Europe in December 2014 for treatment or prevention of phototoxicity in adults with erythropoietic protoporphyria. Off-label uses. Several drugs are used off-label by patients with erythropoietic protoporphyria. Ursodeoxycholic acid is a bile acid that is administered to promote biliary secretion of protoporphyrin. Results of its use in erythropoietic protoporphyria are controversial. However, it is known to alter the composition of bile, to protect hepatocytes from the cytotoxic effect of hydrophobic bile acids, and to stimulate biliary secretion by several distinct mechanisms. Hematin appears to reduce excess protoporphyrin production in the bone marrow. It has been administered to patients with erythropoietic protoporphyria, 3 to 4 mg per kilogram intravenous, who develop a crisis after liver transplantation. Plasmapheresis can also decrease the levels of protoporphyrin in plasma, however its use in treating acute episodes is controversial. Cholestyramine is an orally administered resin which reduces circulating levels of protoporphyrin by binding to protoporphyrin in the intestine and, hence, interrupting the enterohepatic circulation. It is usually used in combination with other treatment approaches. Activated charcoal, like cholestyramine, binds to protoporphyrin in the intestine and prevents its absorption. It is cheap and readily available. It seems to be effective in reducing circulating protoporphyrin levels. Bone marrow transplantation, liver transplantation, acetylcysteine, extracorporeal albumin dialysis, parenteral iron and transfusion of erythrocytes are alternative plans for treatment of erythropoietic protoporphyria. Otc supplements. Some over-the-counter supplements may help. Proferin is an oral heme supplement which may work similarly to hematin. Bacillus subtilis produces ferrochelatase, which may be able to convert some of the protoporphyrin in the intestine into heme. Beta-carotene, though a recent meta-analysis of carotene treatment has called its effectiveness into question.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.